Welcome to the Hospital Medicine Unplugged podcast. We are diving deep today into what is, I think, arguably one of the most complex and critical preventative measures we manage in the inpatient setting. That's evidence-based prophylaxis against deep vein thrombosis, or DVT.
It really is a massive clinical focus, and absolutely rightly so. Venous thromboembolism, VTE, it still remains a leading cause of preventable morbidity and mortality.
It really does.
And when you look at the breakdown, DVT accounts for, roughly two-thirds of all VTE cases? But it's that transition to pulmonary embolism, PE, that really drives the majority of VTE-related fatalities.
And the staggering imperative for us in hospital medicine, it just stems from the epidemiology, doesn't it?
Right.
Globally, something like 55 to 60% of all VTE events are classified as hospital-associated.
Right.
Which means the risk crystallizes either during the admission itself or, within that crucial 90-day window right after discharge. That percentage, it really rests squarely on our shoulders in the inpatient setting.
Precisely. And I think our mission today needs to be moving beyond just sort of habit-driven prescribing of prophylaxis. We need to engage in truly systematic, evidence-based risk assessment.
Yeah, get beyond the reflex.
Exactly. We need to dissect the current guidelines, really focusing on appropriate agent selection, navigating those high-stakes decisions around bleeding risk, and importantly, tailoring strategies for those highly complex populations. Orthopedic patients, cancer patients, those with renal failure.
Okay, so let's start maybe at the beginning with the fundamental mechanism of risk.
Right.
To really understand effective prophylaxis, we have to revisit Virchow's triad. It perfectly encapsulates why a patient admitted to the hospital, almost regardless of their primary diagnosis, becomes inherently prothrombotic.
It does. The three classic components, venous stasis, endothelial injury, and hypercoagulability, they're often simultaneously present in the acutely ill inpatient. Venous stasis is probably the most obvious consequence of being in the hospital, right? Prolonged bed rest, immobility, which we often define as 3 or more days, and even just reduced muscle pump function because of sedation or pain. That stasis allows localized pooling, and that creates the substrate for clot formation.
And then the endothelial injury, well, that's simply a byproduct of modern medical necessity, isn't it? Trauma, major surgery, and especially our increasing reliance on central venous catheterization, whether we're talking central lines or PICC lines, these all directly damage the vessel wall. And that injury exposes procoagulant tissue factors, kicking off the intrinsic clotting cascade.
And hypercoagulability, that's perhaps the most nuanced component. It's often driven by the acute illness itself. We see this spike in inflammatory states, sepsis, severe pneumonia, acute exacerbations of heart failure, and of course, active malignancy. That inflammatory response releases cytokines that directly modulate clotting factor activity.
Right, and we even have research that specifically tries to quantify this risk in acute critical illness. Like in sepsis, hypercoagulability is often signaled by an elevated D-dimer.
Reflecting clot turnover.
Exactly, reflecting increased fibrinolysis reacting to high clot turnover, and sometimes low fibrinogen, which is being rapidly consumed. What's particularly interesting, I think, is the link between VTE risk and respiratory compromise. So where a low pay-oro-euro ratio, often seen with ARDS or severe pneumonia, is independently associated with a higher thrombotic burden.
That really speaks to the systemic nature of the acute inflammatory state. It's not just localized. And we absolutely cannot forget the cumulative effect of the established risk factors. We have to move past just the acute illness and look at the patient's baseline profile. Non-modifiable risk factors like advanced age, particularly patients 70 years or older, they significantly increase that baseline risk.
Yeah, age is a big one.
And a prior history of VTE, whether it was a DVT or a PE, that's perhaps the single strongest predictor of recurrence.
Absolutely. And an active cancer diagnosis fundamentally alters the coagulatory status. It makes these patients hypercoagulable almost by default, even before any chemotherapy starts. Then you layer on the comorbidities that are so common in our hospital populations: congestive heart failure leading to circulatory stasis, respiratory failure needing mechanical support, or even severe dyslipidemia, which itself is an independent marker for vascular inflammation.
We also look at lifestyle and demographic factors. Major surgery, recent trauma, obesity, which we now recognize is its own hypercoagulable male sex, and specific demographic backgrounds like Black race, where studies show a higher VTE risk burden. Hormonal therapies, smoking, alcohol use, they all contribute to this complex, multifactorial risk matrix. The key, and this is mandated by the American Heart Association and ACCP, is recognizing that risk is maximized when multiple factors converge.
Which forces our next discussion. How do we systematically measure this convergence? How do we quantify it?
That really is the pivot point. Clinical gestalt, Our gut feeling, while it's important, it's just insufficient. Major societies demand this shift from the historical universal prophylaxis approach to an individualized risk-based strategy.
Because the whole clinical goal here is exquisitely delicate, isn't it? We are balancing the benefit of preventing a VTE against the very real and immediate risk of causing a catastrophic iatrogenic bleed.
Exactly. And this is precisely where validated VTE risk scores provide that necessary structure. They move the decision from subjective judgment to more quantifiable parameters. Now, while the Caprini score is primarily validated and widely used for surgical patients, where a score of 2 or greater indicates increased risk and 5 or greater is deemed high risk, we really need to focus on the medical inpatient scores for this discussion.
Right. For our medical inpatients, we rely predominantly on the Padua prediction score and the improved VTE risk score. These tools are designed specifically to identify the acutely ill medical patient, the one with sepsis or heart failure, who might not have obvious post-surgical risk, but who is critically ill enough to tip the scale toward thrombosis.
And in both the Padua and improved models, a score of 4 or greater signals high VTE risk. That generally mandates pharmacologic intervention unless there's a clear contraindication. The key difference in their structure kind of helps illustrate their clinical purpose. Padua focuses heavily on things like prior VTE history, active cancer, and mobility restriction.
Whereas Improve incorporates factors like length of stay, certain lab values, and maybe COPD.
Right, and it's probably worth mentioning the Corona score too, even though it's used more outside the inpatient setting.
Yeah, for ambulatory cancer patients.
Exactly. Its primary utility is predicting VTE risks, specifically in ambulatory cancer patients getting chemotherapy, and it definitely influences how we view that population when they were admitted to the hospital for acute issues.
Okay, but let's address the elephant in the room regarding these models. Their clinical utility isn't perfect, is it?
No, it's not. Sensitivity and specificity vary quite widely, depending on the study and the population.
Yeah.
And some analyses looking at model-based versus universal strategies have raised some fascinating questions about, well, cost-effectiveness.
Yes, that's a critical insight that often gets glossed over. The argument basically goes that if we meticulously spend time and resources applying a model that is, say, only 70% sensitive, the cost of the labor, the inevitable patients who get missed, and then the subsequent VTE treatment might actually exceed the cost of simply providing pharmacologic prophylaxis to all eligible medical patients without documented contraindications.
That's a very pragmatic viewpoint.
It is.
But importantly, it doesn't undermine the mandatory nature of using the scores. The scores still provide immense value in 2 crucial areas. First, they are indispensable for identifying the very low-risk patient, typically a Padua score less than 4, who can safely forego prophylaxis entirely. This protects them from unnecessary drug exposure and potential bleeding harm.
Good point. Avoiding harm in the low-risk group.
And second, they focus our attention and our resources on the very high-risk patients who stand to benefit most substantially. This helps ensure adherence is maximized in the population where it really matters most.
Okay, so the takeaway seems clear. While the scores might not save money universally across the board, they are essential for optimizing patient safety and resource allocation. They help us avoid overtreating the low risk and, crucially, undertreating the high risk.
Precisely. So once that high-risk population is identified, the next critical step is selecting the appropriate agent. And for the vast majority of high-risk patients who lack contraindications, pharmacologic prophylaxis remains the absolute foundation.
The primary agents recommended by major bodies like ACCP and AHA include low molecular weight heparin, LMWH, unfractionated heparin, UFH, and fondaparin X. LMWH, often using enoxaparin as the common example, has several advantages that make it a frequent first-line choice.
Yeah, LMWH offers convenience, right? Typically once-daily dosing, which greatly aids nursing workflow and compliance, especially outside of, say, critical care units. And crucially, LMWH carries a significantly lower risk of heparin-induced thrombocytopenia, HIT, compared to UFH, though importantly, it's not zero risk.
Right, and the standard prophylactic dosing for enoxaparin is 40 milligrams once daily. But this is where patient safety really hinges on attention to detail. We must always, without fail, remember the renal adjustment.
Absolutely critical.
For any patient with a creatinine clearance less than 30 ml/min, that dose must be reduced to 30 milligrams once daily.
Missing that renal dose adjustment is just a high-stakes clinical error. LMWH is primarily renally cleared. If the dose isn't reduced in severe renal impairment, the drug accumulates. You get a dramatically prolonged half-life, elevated anti-oxy levels.
And we're not talking about a little extra bruising here.
No, not at all. We are talking about a major increased risk of spontaneous, potentially life-threatening hemorrhage, intracranial bleeding, retroperitoneal bleeding. That is exactly why UFH is often preferred in severe renal failure, because its clearance pathway is non-renal.
Right. Speaking of UFH, the standard prophylactic dosing is 5,000 units subcutaneously, usually every 8 to 12 hours. While its efficacy is comparable to LMWH, that Q8 or Q12 dosing introduces, adherence challenges and maybe an increased risk of administration errors, which is partly why LMWH is generally preferred when kidney function allows.
Mm-hmm. And fondaparinux, 2.5 milligrams once daily, that's a factor AZ inhibitor, a synthetic pentasaccharide. It's another acceptable alternative. It's particularly useful in patients with a history of HIT or even suspected HIT, as it doesn't carry the same immune cross-reactivity risk.
We should also probably address the direct oral anticoagulants, the DOACs, in this context. While their primary role seems to be shaping up for extended prophylaxis post-discharge in select high-risk patients, drugs like betrixaban and rivaroxaban, are approved.
Yes, betrixaban, for instance, has demonstrated efficacy in preventing VTE for up to, I think, 42 days after admission for specific acute medical illnesses. However, the current consensus really stresses that routine, universal use of extended prophylaxis post-discharge is not recommended. And that's precisely because of the potential bleeding risk when the patient is unsupervised at home.
That distinction naturally leads us to the role of mechanical prophylaxis then. These agents are definitely not first line. Their use is reserved specifically for patients who have absolute definite contraindications to pharmacologic agents because of an unacceptable risk of bleeding.
Right. The two main mechanical modalities are intermittent pneumatic compression, IPC, and graduated compression stockings, GCS. IPC sleeves, they apply cyclical pressure to the limbs, and they have demonstrated efficacy, particularly in post-surgical settings. However, it's universally recognized that mechanical methods are generally less effective than pharmacologic prophylaxis.
And the evidence for GCS, the stockings, is actually quite mixed, isn't it? Its use seems to be declining in many institutions.
It is. There are concerns about poor patient compliance, potential skin injury, or pressure ulcers, especially in frail or immobile patients.
And we must encourage early and aggressive ambulation for all patients. That helps venous flow, reduces stasis.
Definitely an adjunct.
But ambulation is an adjunct therapy. It is not, in itself, a standalone prophylactic modality for the high-risk patient.
And perhaps the most critical safety decision we make day to day is that daily reassessment of bleeding risk. We cannot assume that just because a patient tolerated prophylaxis yesterday, they will tolerate it today.
Their clinical status is dynamic. That line between prophylaxis benefit and hemorrhage risk shifts constantly.
Mm-hmm. The guidelines are pretty robust here, and we really must adhere to them meticulously. Specific contraindications that immediately mandate stopping pharmacologic agents and switching to mechanical methods include any evidence of active bleeding.
Right. That includes, but isn't limited to, significant overt GI or GU bleeding within the last, say, 6 months.
Lab parameters are also essential. Severe thrombocytopenia is a hard stop. We generally define this as a platelet count below 50 times 10 to the third per microliter. Additionally, a significant uncorrected coagulopathy like a prothrombin time over 18 seconds, or an INR greater than 2 in someone not already therapeutically anticoagulated, that makes pharmacologic prophylaxis just too dangerous.
And of course, a confirmed or suspected diagnosis of heparin-induced thrombocytopenia, HIT, immediately contraindicates both UFH and LMWH, no question there.
Right. Other contraindications relate to high bleeding risk anatomical sites or recent procedures. This includes recent high bleeding risk procedures, like a liver or renal biopsy done within the last 24 to 48 hours.
And the central nervous system risks are paramount. Any history of intracranial bleeding within the last year, or the presence of an active intracranial lesion, a neoplasm, or even a monitoring device.
Absolute contraindication.
Yes. And this high level of caution extends to patients with acute stroke, particularly hemorrhagic stroke, or those who've sustained severe head, spinal cord, or major extremity trauma within the last 24 hours. The risk of delayed hemorrhage is just too acute.
And something often overlooked, perhaps, are the underlying chronic organ failures that impact drug clotting factors. Severe chronic kidney disease, which we've touched on, or severe liver disease, which often leads to complex factor deficiencies or platelet dysfunction.
These are significant contraindications, too.
They are. The sheer number of these contraindications really underscores the need for standardized order sets that force a bleeding risk assessment before the drug is administered.
Exactly. If any contraindication is present, the prescription must be held, and the mechanical alternative needs to be utilized.
And interestingly, data show that in clinical practice, adherence to stopping prophylaxis when these severe contraindications arise, like active GI bleeding or profound thrombocytopenia, is actually quite high.
That's good to hear.
It suggests clinicians do recognize the severity of these specific bleeding risks.
Okay, moving beyond the general medical population, let's focus on some special cohorts that require really highly tailored prophylaxis strategies. Starting with orthopedic surgery patients, these patients represent one of the absolute highest risk groups for postoperative VTE, particularly total hip and knee arthroplasty patients and those undergoing hip fracture surgery.
Oh, absolutely. The sheer trauma involved, plus the required immobility, make VTE almost a certainty without some intervention. The crucial distinction here is often the duration of prophylaxis. The risk extends well into the post-discharge period. Guidelines mandate a minimum duration of 10 to 14 days, but for the highest risk procedures like total hip replacement, prophylaxis is frequently extended up to 35 days postoperatively.
Right. If we stop at discharge, we're missing that peak risk window entirely.
We are. And the agent selection in orthopedics is also notably broader than in general medicine. While LMWH remains a strong preferred option when feasible, several alternatives are acceptable because they have established efficacy in randomized trials specifically for this population.
Such as
DOACs like apixaban, piazopin, dabigatran, and rivaroxaban, rivaroxaban. Also adjusted dose vitamin K antagonists, UFH, or even aspirin in some cases.
Ah, yes. The debate over aspirin in orthopedics is particularly fascinating, isn't it?
It is. Recent evidence suggests that low-dose aspirin might be an acceptable, cost-effective, and reasonably safe alternative in certain low bleeding risk, high VTE risk, elective orthopedic procedures. The choice ultimately boils down to balancing efficacy, patient preference for oral agents, and the specific surgical bleeding risk profile.
Okay, next challenging group, cancer patients. A population characterized by that intrinsic hypercoagulability driven by tumor burden, inflammatory cytokines.
Yes, and inpatient cancer patients have highly heterogeneous VTE risk profiles. It's not monolithic.
Right.
This is where we rely heavily on risk stratification tools again, maybe emphasizing the Corona score to help guide management, particularly in the ambulatory setting, which informs inpatient risk. For prophylaxis and critically for the treatment of established VTE in this cohort, LMWH is generally the agent of choice.
That preference for LMWH seems pretty robustly evidence-based, partly due to maybe some suggestion of potential anti-cancer effects, but mainly its superior track record in reducing recurrence without increasing major bleeding and malignancy compared to, say, vitamin K antagonists.
Exactly. And we must strongly advise against routine primary prophylaxis for ambulatory cancer patients just receiving standard chemotherapy. The number needed to treat to prevent one VTE is generally too high to justify the bleeding risk for everyone.
The key exceptions being those on specific high-risk regimens like thalidomide or lenalidomide used in multiple myeloma.
Correct. And a major safety note regarding DOACs in cancer. Caution is paramount when using them in patients with active gastrointestinal or genitourinary malignancies. Studies indicate a concerningly increased rate of bleeding specifically at those tumor sites compared to other cancers or compared to LMWH.
So that requires meticulous risk assessment and really site-specific consideration when you're prescribing oral agents in that context.
Absolutely.
Okay, shifting gears again to patients with renal failure, a really common inpatient challenge. This presents a significant pharmacological hurdle, particularly regarding LMWH.
The line in the sand is pretty clear. Creatinine clearance less than 30 mmol. As we discussed, LMWH accumulates in severe renal impairment, leading directly to higher bleeding risk. Therefore, unfractionated heparin, UFH, is the preferred agent because its clearance is non-renal.
Plus, its short half-life makes it easily reversible if bleeding does occur.
Precisely. Now, if an institution strongly favors LMWH and feels they must use it, perhaps dalteparin, which might have slightly more favorable pharmacokinetics in renal impairment, though the evidence is a bit mixed.
Then rigorous monitoring is key.
Absolutely essential. Monitoring with anti-SLI levels is needed, along with highly conservative dosing. Ignoring the CRCL cutoff is simply not an option for safety-conscious hospitalists.
Agreed. Finally, let's touch on the obese patient population. This presents a major dosing dilemma. Obesity is a recognized independent VTE risk factor.
It is. But standard weight-based LMWH dosing is based on studies of non-obese populations.
So the uncertainty regarding optimal LMWH dosing in severe obesity, let's say defined as a BMI greater than 40 kilojoule to 2, it forces us into this realm of clinical judgment that kind of goes beyond standard guidelines.
It really does. We have some meta-analyses suggesting that using higher than standard LMWH dosing, perhaps intermediate dosing, may reduce VTE incidence without a proportionate increase in bleeding risk. However, the robust randomized data to universally support this dose escalation, it's still lacking.
So for these patients, individualized assessment is critical, sometimes relying on monitoring peak anti-DASI levels to ensure adequate prophylaxis, especially if the patient is deemed very high risk otherwise.
Right. And for DIATs, current data generally supports their use up to a BMI of 40 kilograms too. But for those with severe obesity beyond that threshold, evidence is quite limited. That often favors UFH or LMWH with careful monitoring due to concerns about potentially reduced drug absorption and efficacy.
Okay, turning now to system-level interventions. It's, well, frustrating to acknowledge that despite clear guidelines, patients still miss prophylaxis doses or aren't assessed properly.
It is frustrating. And it often boils down to operational barriers, doesn't it? Physician failure to risk stratify consistently, nursing failure to administer or reconcile missed doses, gaps in patient handoffs or education.
Yeah.
The literature strongly advocates for system-wide interventions because individual education alone, while important, is often insufficient to change practice reliably. Highly effective strategies include mandatory computer-based alerts integrated right into the CPOE system.
Computerized order entry.
Exactly. These alerts prompt the physician to select a VTE risk level and explicitly order prophylaxis unless a contraindication is documented. It forces the decision.
And the data supporting these alerts is pretty compelling, isn't it? Studies have shown that when these automated risk assessment and ordering prompts are implemented rigorously, they significantly reduce the rate of symptomatic VTE measured at 3 months post-intervention.
It's a mechanism that forces compliance and standardizes the process across the board.
What about other strategies?
Other successful multifaceted strategies include things like dedicated VTE prevention teams or champions, human alerts or reminders for nursing staff about missed doses, and the use of pre-printed order sets for specific high-risk admissions like orthopedic or trauma cases. Basically, standardizing the clinical path reduces that unwarranted variation.
Now, a critical issue that extends beyond the immediate hospital stay is the post-discharge problem. We know that the majority of VTE events actually occur within those first 6 weeks following discharge.
Right when the patient is recovering, but surveillance is essentially dropped off completely.
So what's the status of extended prophylaxis then? It seems nuanced.
It is nuanced and, frankly, fraught with decision fatigue sometimes. Routine universal use is actively discouraged, because as soon as the patient leaves the facility, that bleeding risk is managed outside of a highly controlled environment.
Right.
So extended prophylaxis, often using DOACs like Patrixaban or Rivaroxaban or Auroxaban for maybe 30 to 45 days, it's strictly reserved for a select few.
And the ideal candidate for that extended prophylaxis would be?
A patient with demonstrably high VTE risk, for instance, someone with severe acute medical illness who meets specific criteria, or certain post-op cancer patients, who also has been meticulously confirmed to be at low bleeding risk.
Yeah.
It requires a very clear risk-benefit analysis that has to be communicated effectively to the patient upon discharge.
Okay. This brings us maybe to the horizon of research where clearly much work remains to be done.
Definitely. We still lack clear consensus on the optimal duration of prophylaxis, particularly post-discharge for non-surgical patients. Refining our risk stratification tools is also paramount, specifically by integrating validated bleeding risk scores alongside the thrombotic risk scores, trying to create maybe a single unified decision model.
That would be helpful.
It would. And therapeutically, I think the most exciting area involves emerging agents. We're closely monitoring the development of factor kinase inhibitors.
Factor 11. Okay.
These agents selectively inhibit factor EOI, which is an upstream component of the coagulation cascade. But the theory is that factor EOI plays a greater role in pathological thrombosis than it does in normal hemostasis.
Yeah. So potentially separating the antithrombotic effect from the bleeding risk?
That's the hope. If that theory holds true in large-scale human trials, factor and KIVI inhibitors could potentially offer, well, the holy grail of anticoagulation, high efficacy against VTE while offering a significantly improved safety profile. reducing the risk of major bleeding complications associated with our current agents.
That would fundamentally change prophylaxis management, wouldn't it?
It really would.
So, wrapping this all up, what does this entire deep dive mean for your practice today?
I think the overarching principle of evidence-based DVT prophylaxis hinges entirely on systematic, individualized risk assessment. It requires diligence, moving past clinical habit, and achieving that careful, dynamic balancing of the patient's VTE risk against their bleeding risk. And all of that needs to be supported by robust system implementation protocols that ensure adherence.
Our core responsibility as hospitalists is really to make these high-stakes decisions every single day, protecting the patient from both thrombosis and iatrogenic hemorrhage. So given the known challenges we've discussed, model heterogeneity, the cost-effectiveness debates, the ever-present pressure of managing competing risks, here's a critical question for you, the listener, to consider. How can local hospital protocols best integrate both validated VTE risk models like Padua or Caprini and rigorous bleeding risk scores into a single mandatory workflow? A workflow that ensures the optimal individualized prophylaxis decision is made for every single patient every single day, not just at admission, but throughout their entire stay. That demands a commitment to proactive rather than just reactive prevention.